Okay, good afternoon, everyone. So when I was thinking this morning about giving this talk, I did a run around the hotel, and I realized the last time I gave a talk to real people rather than a computer screen was in Denver, which made me very nervous because that's been a while. And so I started thinking about, well, what have all the experts taught me about preparing for something like this? So I thought about Eric Pepper telling us to redo the narrative so that it has a positive outcome. Thought of Ina Kazan, who would tell me to just mindfully allow this talk to happen. And then, of course, what I did was avoid and distract, which is my typical approach. And I put together a series. These are all podcasts that are hosted by members of AAPB. So instead of actually working on my talk, I thought, what should we all be listening to? And so I put some of these out there. And I really do urge all of you to listen to at least some of these podcasts. There are a few other podcasts out there. There's another HRV, there's an elite HRV podcast. There may be others by AAPB members, but I don't know what they are. So to start my actual talk, this is a symposium on long COVID. And we're going to skip the introductions because we want to put more time into the actual talk. And I'm going to be giving the high altitude part of this talk on the condition, what our healthcare system is doing. And Shari is going to talk a little bit more, she's going to delve more into the details of treatment. And of course, Jay will detail the neuroanatomy. Now, in order to understand something, I would argue that it's useful to define it. And defining something as complex or as new as long COVID is actually quite difficult. This is the working definition for the United States, and you can see how broad it is. And there are lots of ways to pick this definition apart, which we could spend time doing, but let's not waste our time doing it. Now, as a reflection of how new this condition is, I've actually updated this talk several times, even in the last few days, as new data come out, new policies, new studies. So, for example, there is now a more systematic attempt at a first definition. And as often happens, as we better understand something, we come up with much less interesting names for it. So we're talking about post-acute sequelae of SARS-CoV-2 infection, or PASC. I'm going to continue to call it long COVID or long haul COVID, just more interesting sounding names. This was a study put out by JAMA just about less than 2 weeks ago. It's based on the NIH researching COVID to enhance recovery, the RECOVER initiative. And this is a US-based entity for studying, understanding, and coming up with treatments for COVID and now for long COVID. In this particular study, there were almost 10,000 participants. Not all of them had COVID. And without going into too much detail of the study, they looked at the 37 most frequently reported symptoms and used statistical modeling to kind of winnow that down to 12, which you can see on the right side of the slide here. And what they found was up to 21% of participants would meet criteria for PASC. And that was varied based on a variety of factors, the cohort, the variant, and there are other risk factors that we already know about long COVID. Older people are more likely to get it, females are more likely to get it, and people who have pre-existing health conditions. Now, the probability of getting long COVID, that sort of 10 to 20%, is based on infection. So I want to just take a minute to look a little more closely at that. Now, a lot of people have had COVID, maybe everybody in this room. But I'm curious how many people either have had or know somebody who's had COVID twice? 3 times. Anyone know anyone 4 times? 5 times? Okay, not so many, but at least 3. Most people in this room have known people that have had it at least 3 times. That's in 3 years. So it's a pretty common virus to catch. Now, let's assume that everybody has an equal chance of infection, of developing long COVID per infection, which is not true, but again, I don't want to get too much into the details. If it's a very low chance, say a 1% chance per infection, over 10 infections, it's still pretty low probability that you're going to develop long COVID. At a 5%, gets a little higher. And in fact, over 10 infections, you're approaching 0.5 probability of developing long COVID. As we get to, where the study, the range of study was suggesting 10%, after 6 or 7 infections, you're above a 0.5 probability of developing long COVID. At that higher range, 20%, it's getting higher. 6, 7 infections, you have above a 0.75 probability. And if it's higher, and for some people it is, 30% or even 50%, you're going to have long COVID. Now, this is a very simple model. It's overly simplified. It doesn't take into account a lot of variables. It doesn't take into account that rates of infection are in fact going down. But we certainly hear that COVID is something that's here to stay and we need to learn to live with. And given that, again, we're only 3 years into this. So imagine over a person's lifetime how many times they might catch COVID. And so the probability of developing long COVID is actually probably pretty high. So we need to keep that in our minds as we consider both healthcare policy, but also what we as clinicians and as providers are doing. Now, what does COVID look like right now? As of April 2023, the WHO is estimating there's 760 million infections with 7 million deaths worldwide. CDC in the US is predicting 104 million, 1.1 million deaths in the US. The CDC actually just stopped providing these estimates because of the end of the emergency COVID order. One of the things that happened is they don't have the resources to do this. Plus, fewer people are getting tested. So we just don't have the data. Now, if 20%, it's a bit of high estimate, but if 20% of these people get COVID, that's 21 million in the US, and that's 152 million people worldwide right now. Doesn't include people who get COVID later on. Now, while the PASC study has looked at 12 symptoms, in fact, there are over 200 documented symptoms of long COVID. So this is a complex syndrome that is really overwhelming a lot of healthcare systems. Now, I've spent a lot of time talking about probability, and our time is worth a lot since we don't have enough. And the reason I do that is because I think it's really easy to lose sight of the human factor or the human cost of all of this. We have the statistics, the uncertainty, ongoing changes of what we know, even we have politics involved in this. Many of us have worked with patients who have long COVID, and we're all affected by it. And I think we need to really keep in mind what that means for ourselves as individuals and for our society. So just like the HIV pandemic, which started over 40 years ago, in which this quote relates to, COVID is more than the data on spread. It's more than variants, vaccination rates, morbidity, or mortality. It's the stories of the individuals who are infected and the consequences they and all of us are experiencing. So in this symposium, we're going to focus on this one lingering aspect of the COVID pandemic, of our most recent pandemic. And we're going to share the data, and we're going to talk about treatments and interventions. But we're also going to really highlight a few of the patients that we've worked with. So what does this look like when someone comes into the room? Well, I listed those 12 symptoms. And until that PASC study came out, they were kind of grouped into about 7. The most serious are typically considered the respiratory and cardiac for obvious reasons, but there can be stomach, GI pain, discomfort, weight loss, weight gain, tinnitus, loss of taste, loss of smell, fatigue. There could be general fatigue. There could be an inability to or reduced capacity for exercise. There could be post-exertional malaise, so PEM, that's about 12 hours after you exercise, you're knocked out. And about 90% of patients with long COVID are reporting post-exertional malaise. Dysautonomia, heart palpitations, orthostatic hypotension, postural orthostatic tachycardia syndrome, POTS, and about 80% of long COVID patients are reporting POTS symptoms. Focus, headache, cognitive fog, depression, and anxiety. So what is our healthcare system doing? That is a really good question. There's no plan. There's no sort of central approach to this. And in fact, the NIH states that there is no specific treatment for long COVID yet. So what typically is happening is focus on treatments, a lot of pulmonary rehab, autonomic conditioning, cognitive rehab, smell retraining, psychosocial behavioral therapy, of course. There are lots of post-COVID care clinics popping up. In fact, in the US, there's at least one in every state. But there's no unified guidelines or consensus statements until about a week ago, actually. There's now one, and it's put out by the American Academy, by the American Academy of Physical Medicine and Rehabilitation. Not surprisingly, they're focused on neurologic symptoms. And so they put out a set of guidelines for treating symptoms within the context of long COVID. And they're really the first to do that, as far as I know. So there is one unified guideline and consensus statement. They do tend to start with an interdisciplinary assessment, which makes sense. This affects every system in the body. Some are interdisciplinary, some are more focused. A lot of them are, say, pulmonary related. And the approach is frequently self-care. So in one of the, I think, best descriptions of what to expect, Yale Medicine lays out what they'll do for each of those sort of 7 classes of symptoms. And if you look at this, you can see that it's a lot of behavioral work, which of course is the entree for all of us. There are more studies coming out with what I'm going to call experimental treatments. I don't mean they're crazy, wacky things. I just mean there's no evidence base here. But there are studies with control groups that are showing steroids for olfactory dysfunction, transcranial alternate current stimulation for visual impairments, oxygen and cognitive behavior therapy for fatigue, and guanfacine and neurofeedback seem to help with brain fog. So there are some, we're starting to build up a too slow evidence base. So that's sort of the altitude. And I'm going to present a case, and then Shari will take over and provide you with a lot more detail than I have on those interventions and what we take a look at. And then, of course, Jay will talk a lot about the neuroanatomy. So I'm going to present a case which in many ways is typical, in some ways it's not. And this is Kay, who is a 50-year-old male. We started working together in the fall of 2021. And this was before long COVID was even really recognized. It was minimized. It was dismissed. In fact, he was sort of shunted from doc to doc. And then he finally started doing his own research and decided, let me try this neurofeedback thing. His presentation was pretty typical. He had been infected with COVID 8 months prior, was experiencing photophobia, orthostatic hypotension, some vertigo issues, tinnitus, myoclonus, particularly when falling asleep, auditory processing, and fatigue, the cognitive fatigue. When he came through the door, the cognitive fatigue was the biggest problem in his mind. Now, he was generally healthy. He did have a migraine history, which probably wouldn't surprise you from this. He had had a concussion 5 to 7 years prior to seeing me, and he had some insomnia, both onset and maintenance, and some reflux. But other than that, he was healthy. Now, this particular case, this was in the context of developmental trauma. His parents divorced when he was 5 years of age, and his father did remarry pretty quickly. He describes his father as abusive, alcoholic, physically and psychologically abusive, both to him and to the new step family. And he witnessed a lot of that growing up. He eventually broke off contact with his father and had no contact with him until the father actually passed away in 2021. Growing up, he describes his mother used him as a confidant and really shared a lot of intimate details of her own life with him. And he now has what he calls an arm's length relationship. When he was 15, he witnessed his stepbrothers attempting to commit suicide. The two of them were alone in the house. The stepbrother tried to cut his wrists, or did cut his wrists. Kay came onto this, called 911, dealt with it, but obviously another traumatic event. So he'd been in psychotherapy keep doing that. He'd been in psychotherapy for over 25 years, primarily internal family systems type. And then about 2 years before we started working together, he started working with a psychotherapist who integrated some EMDR, and he was finding that useful. Married with adolescent son. He had converted to Catholicism, and it was very important to him. And in fact, he had not been able to go to church for 8 months since he was infected with COVID or the coronavirus. He was had a pretty high level intellectual job, was physically active, played a lot of tennis, not for a few months. And he enjoyed intellectual hobbies. So before he got COVID, he was teaching himself Polish, not because he was going to Poland. He's not a Polish heritage. He just liked the language. So this is the kind of thing he liked to do, but he really wasn't able to at this point. He was on medical leave from his job. He couldn't read, couldn't use screens. He was doing almost no physical activity. At that point, he had been working with a functional neurologist, which I think was really, really good. And he was on a variety of medications, so sertraline for PTSD, trazodone and melatonin for sleep, Botox and atriptan for migraines, and he was on a proton pump inhibitor. Now, I'm going to present a very streamlined picture of our treatment. It lasted over a year, and there was a lot of trial and error. I'm going to skip some of that anyway. And there were things that kind of, we had little detours here and there when he would get anxious, or I had to cover for his primary clinician, things like that. So I'm just going to kind of skip over all that stuff and really focus on the applied psychophysiological parts of our work. So started with a QEEG, and since Jay is here, I don't know if you can see this, but since he is here, I will show you some of the raw EEG. This is eyes open, and while it's probably hard to see, there is a whole chunk of slow activity centrally. Similar with eyes closed. And then the spectra and brain maps for eyes open, you can see that red dominant rhythm, that's slow activity in the center. There's also some fast activity in the center, and a similar picture with eyes closed. So this is a dysregulated brain. His PDR was about 9.5 to 10 hertz, so pretty normal, but I suspect his real posterior dominant rhythm was probably higher, just given who he is. So for our training plan, phase 1, we started with heart rate variability, and that's something that I frequently start with, regardless of who walks through my door. We all know why. Does a lot of autonomic regulation, but also zips up to the central nervous system as well. I did some PIR HEG, passive infrared HEG. I like that for kind of getting that frontal lobe a little bit better regulated. And then amplitude training, really focusing centrally, doing SMR training. I will call it SMR because it is central. And then a little bit faster frontally. Again, I know Jay's here. I don't know if he's listening, but. So phase 1, training starts, we're meeting twice a week. And I typically start with self-regulated breathing training, moving into HRV training. His baseline RMSSD was below 30, which is low and lower than I would expect it for someone who is physically healthy. But he hadn't been that physically active for a while, and he had COVID. And I think there is some studies, some data showing that COVID infection is related to lower HRV. Could be wrong about that. I may be making it up, but it's true. It is true. There you go. So I taught him self-regulated breathing and did a resonant frequency evaluation. His resonant frequency was 6.5 breaths per minute, which again, I was a little faster than I expected. Truth to tell, he couldn't tolerate going slower. He would just get very distressed. So we kept it a little fast. And he started practicing at home. He was really good at it and continues to be. And almost immediately had some strong trauma-related emotions while doing the self-regulated breathing, paced breathing. Relaxation-induced anxiety. I don't like the word relaxation, but that's what it's called. Relaxation-induced anxiety, 8 to 10% of people. So he was already at risk. So what we did was we shortened it down to like 1 or 2 minutes. He would do it in the office, we'd do it at home, and slowly he built his tolerance up. And at this point, he's doing twice a day, 10 minutes at a time, which is, yay, that's a success for anybody who's tried to get people to do this. So we're going twice a week, and within about 2 months, between the heart rate variability work, this paced breathing, and the neurofeedback, he's starting to get some improvement. The first improvement, which is pretty typical, is better sleep. Now he's wearing a sleep monitor, so he comes in and tells me, my REM sleep is back to normal. Okay, and so he's excited. He's also feeling better, which is good. He actually goes off the melatonin. His migraines are reduced in frequency. Tinnitus is mixed, so it's sometimes higher, sometimes lower. It's a little bit mixed. He starts working, so he starts working 3 hours a day, 4 days a week. 3 months, most of his symptoms are really improving, even when stressed. So he's not triggering, stress is not triggering migraines, not triggering tinnitus, and he's starting to get re-involved. So he goes to church for the first time in about 12 months, and that was a really big deal to him. But he is feeling more fatigued because he's working more. At least that was and continues to be our working hypothesis. 4 months, he's actually doing really well. And he's working pretty steadily. It's about 4 or 5 hours a day, 4 days a week. And his fatigue is better. Tinnitus is better. Myoclonus is better. Everything's better. And we're talking about, well, let's go down to maybe once a week. Let's do a new Q. And what I really should have done was discharge him then, because of course he got reinfected. And right after reinfection, everything comes right back. So in his fatigue, his myoclonus, his tinnitus, everything comes back, and this bloom of anxiety. So he starts worrying about losing his job, and if he loses his job, how will they earn, how they live? And the truth was, his job was actually really supportive, and he had the right to medical leave. And his wife had a pretty good job, so they would be okay for a while. And he knows all of this, and he knows it's connected to his trauma, but it's still something we had to and did deal with. We decided to do the Q anyway, as soon as possible, because we were sort of curious. I mean, he was very collaborative, very interested in this, and on more than one occasion asked if he could work as my tech. I'm like, no, won't do that. But you can see there is change between time 1 and time 2. So a lot of that dysregulation, central dysregulation, has started to calm down. And if you look at the maps, you can kind of see that as well. And it's similar with eyes closed. Now, what I think was happening was the EEG. You can see some of the EEG has changed if you look at so that upper right-hand side. There's some increase in some of that activity, and that may reflect the reinfection, may just reflect the way that EEG sometimes shifts. But we decided, okay, well, what are we going to do next? So in the trial and error phase, I thought, why don't we try something more global? That sounds good. So in phase 2 of the trials, like an MC universe thing, I decided, let's try a more global approach. So let's try Z-score training. So I do 4-channel Z-score training, and I thought, let's start on the left and then we'll go to the right. We did continue the self-regulated breathing practice, and he continues that to this day, as far as I know. And so Z-score training, I started on the left side. The sites in parentheses are from the 10-10 designation, which I suppose we all should be using. And then decided start there for a while, then shift to the right. I do keep doing that for some reason. Well, as it turns out, left side didn't do anything. There was no change in symptoms. So we shifted over to the right, and symptoms improved right away, particularly with sleep. We're going once a week at this point, doing Z-score training. About 8 months, he starts having problems sleeping again. And so, being a, let's see, Dick and Paul are out there, a card-carrying member of the CBT mafia, I did some CBT for insomnia with him, and it worked. Not surprising. And that helped him. And he actually started sleeping. He was down to about 4 or 5 hours a night. He got up to about 6 to 8. And so things are getting better. The myoclonus improves, the fatigue really improved, and that was a big deal to him. We're hitting 10 months, and symptoms are still there. They're better. Some of them plateaued, but he's kind of getting on with his life a little bit. And so a lot of our treatment shifts a little bit from training to more therapy-like, at least therapy-like, where I'm really trying to focus with him on functioning. So he goes on his first vacation since COVID. He and his wife go out to dinner to a noisy restaurant, does not trigger tinnitus. He starts to play tennis again. Then one day he comes in and says, my wife said to me, I'm more like myself than I was before I got COVID the first time. I'm like, hey, that's when I should have discharged him, but I didn't. 12 months, fatigue is increasing. He's working 27 or so hours a week, and the fatigue is increasing. We can't, we worked with pacing, all the good cognitive tricks, all the good behavioral tricks, and they're not really working. So I consulted with Linda Walker around tinnitus training and shifted my neurofeedback to C3 minus C4 SMR training, along with 2-channel training, T5CZ and T6CZ. And that slowly seemed to get the tinnitus better, but it never got better than before that second infection. So at 14 months, I get a call from his psychotherapist who tells me, he's dissociating. He started to dissociate in session, only in sessions with her. But he meets criteria for a DID. So we think, okay, well, we've got this neurofeedback thing. I read Lanius. Let's try some alpha down on PZ. So we tried that for a little bit. I think it helped a little. And he's kind of stable. Things are stable, but the tinnitus, that's now his primary complaint. So in February of this year, I'm glad Dr. Othmer isn't here, because I referred him out for infralow training. And it worked, sort of. So I actually just talked to him a couple of weeks ago, and the tinnitus had gotten better, but again has plateaued. And he's now looking into the treatments, the sort of hearing aid devices that put off interfering frequencies. So if anyone's worked with tinnitus, they're probably familiar with that. So just why this keeps doing. Quick review. Long COVID in the context of developmental trauma. Took a multimodal approach, and this is just me. I'm only one of a few other providers in this person's world. Cognitive behavior therapy, HRV biofeedback, amplitude Z-score, and infralow neurofeedback. So not a straightforward case, but I don't think any of them are. So a few things that I take in terms of formulating cases like this. This is a condition that has a multi-system impact, and it significantly disrupts life. As providers, as clinicians, as whatever we call ourselves, we need to be flexible. We need to take a multidisciplinary approach. We have to recognize that the symptoms are going to interact with everything else going on in this person's life, and you should really expect surprises. So as I'm coming to the end of my part of this talk, because I've updated this so much, this is a link to where I've put the slides and some references and resources if you're interested. But I want to end my part of the talk with actually a quote from Kay. I asked him a few days ago, and he sent me this quote, and the first thing I thought was, I've got to edit it down, it's so long. But then I thought, you know what, I'm going to keep it, because I think it encompasses a few of the really important points that I'm trying to make here, and I think we're all trying to make here. One, applied psychophysiology can absolutely improve the lives of these patients. And second, we have to do more of this so that we can show patients and medical providers that we can. We bring high value to this. And finally, that we always remember that behind all of this work, and it's kind of interesting because I've heard this message from a few of the talks this week at the conference, behind all of this is a person whose life, he's just trying to live his life. And we have all been so impacted by this, by COVID and by the repercussions. And these are people's lives that we can absolutely enhance. So I'm going to turn this over to Shari.
And I'm going to skip a lot of my slides because
you want this? Here?
Saul, yeah. Saul covered a lot. So a lot of my intro is about, the different variants and why we have different reports of, how many people are coming that had COVID come down with long COVID. And so I'm going to click through some of these pretty quick. This is what we're going to cover. He just covered the latest statistics. So, you'll recognize the naming of the alpha, beta, gamma, delta, and then the Omicron. So the one thing I do want to point out here is, that alpha and delta variant were the most likely to cause neurologic symptoms, which is a lot of people's complaints with long COVID. He covered most of that. So we will skip those. And, and it is interesting that again, these studies were for those first variants before January of 2022. And, the Chinese are kind of a captive audience. And so theirs was actually 50-50. 50% of people who came down with COVID got long COVID. It was a smaller study, but, everybody reported. So I think that makes a difference. I'm going to go through a couple of slides of the symptoms on long COVID, even though Saul covered that pretty thoroughly. There are well over 200 symptoms listed by the CDC today, and I'm going to explain some of how that happens. Here's a good list. One of the, like 80% of people that get long COVID have cognitive effects, but they also have the fatigue and chronic mast cell activation and the ME/CFS, chronic fatigue. And it does reactivate dormant viruses. So, you'll talk to people that had COVID and their immune system is just kind of shot. So they get a lot more infections that take them out where it would have been like a mild cold. I'm going to talk a little bit about the mechanism of COVID-19. The COVID virus is covered in this spike protein, and that binds to ACE2 receptors. And with those ACE2 receptors throughout the body, including our astrocytes, glia, and neurons, it can bind to these cells, and then the S protein transfers its replication DNA to the host cell. So when our body's AB cells grab this S protein, it creates an imprint, which is then transferred to the other cells. This is why COVID-19, is characterized by the cytokine storm, because whether it's the spike protein itself or our own immune system replicating that and spreading it to every organ, that's why we have this inflammatory cytokine storm that you hear people talk about. And the S protein has been found in monocytes 24 months post-COVID infection. So that when we're looking at, what are the therapies that are going to be helpful, I think what I learned, not in my first case, which I'm going to share, but in the subsequent cases that I've worked with, is making sure that there's a detox, that there's not still an inflammatory or the viral cause or the imprint cause that's still inducing this inflammatory response. So I think that's pretty much when there's several ways that COVID gets into the brain. The trigeminal nerve passes the blood-brain barrier. It attaches to all of these different cells, the astrocytes, the microglia. And it's the, ACE and blood circulating pathways that are the most obvious way for COVID to enter the central nervous system. The other thing that people don't think about is the endothelial damage that's done by the spike protein and by the inflammation. And this is why we see so much vascular ischemia in long COVID. So I'm going to spend a little bit of time on the neuromodulation and biofeedback therapies that Saul didn't cover. What I see in our clinic, and probably 25% in the last 2.5 years of my clients have been long COVID cases. So I would encourage you to put COVID-19 on your questionnaire. And also I ask, what was the date? Because what I have found is, again, if they had it before January of 2022, they're much more likely to have the neurological symptoms. And that's often what brings them in. But people who've had COVID don't necessarily relate something that came on 3 months after they, tested negative for the virus as a COVID related response. They just now have chronic fatigue. They now have the post-exertion malaise. They now have all the cognitive brain fog, and I can't read and I can't sleep and I can't do work. And, if I study for my test, I'm exhausted for 2 days afterwards. So, short-term memory, verbal fluency, word recall, etc., are major complaints. Neurofeedback, the reason I want to do this talk is because I know all these people exist. We're talking 20 million people in the US with long COVID, and they're not getting help from their traditional doctors. I'm in Colorado. We have a lot of functional medicine practitioners, and those guys have, actually gotten on board, and I work with a lot of functional medicine practitioners. I actually have Dr. Michael Pierce in my office who helps with this as well, with the nutritional and gut issues, because that's all part of it. What we see in the EEG and the raw EEG is slowing of the EEG. I see a lot of left temporal, but also bilateral slowing, and that slow edge of alpha that indicates the ischemic change. We see a lot of frontal slowing, even encephalopathies. Slowing of the alpha peak frequency. I've known a number of people who lost a full cycle a second due to the neurologic changes in their brain. And then spindling excessive beta, which could account for, a lot of the tinnitus and anxiety that our clients are coming in with. So what I want to say is, we're underutilized as practitioners to help with this new pandemic of long COVID. Neuromodulation and neurofeedback and biofeedback can improve, your sleep. Well, that's how the brain clears out problems, is going through its normal architecture of sleep. There was just a study about, gamma, I think it was Lou Lim's, about, gamma modulation helping to clean out tau proteins, et cetera, when you sleep. So, that's the work of sleep, is to help heal the brain. We want to also do things that return people's sympathetic parasympathetic balance, which Saul talked about. One thing that people don't think about is neurofeedback is always helping with blood flow and metabolism. And I've got a slide, Jay's perfusion slide, that I'll show you. And then also we're reducing inflammation. I don't know if any of you have read the book on the angels and the assassins, but it's talking about the glia, and either they are in defense mode and causing autoimmune problems, because again, that spike protein replication is causing autoimmune disease, or they can turn into angels and help with growth and repair. So it's a fantastic book just about the glia and the microglia. And then another study that just came out showed that people with long COVID have a 2% reduction in their gray matter volume. So we also know that we can increase gray matter volume through neurofeedback. And we can increase ATP, restore mitochondrial function, which helps tremendously with the fatigue, the brain fatigue aspect, but also body. There's the blood flow chart. So if we can increase blood flow, we can increase neural reactivation. So I use neurofield stimulation, PEMF. I use home devices. So, you were talking about the things that your patients can do at home, HRV, but they can also, especially for POTS, use cranial electrical stimulation and, on the vagus nerve, and that will help with POTS. I haven't even told my own story, but 2 years after working with a lot of of long COVID clients. I got COVID and long COVID myself. And I would say 6 weeks of training with cranial electrical stimulation on the vagus nerve actually helped me be able to get back to work. Took about 6 weeks. Red light therapy, photobiomodulation, increases ATP, nitric oxide is released in the cell, and it increases blood flow and oxygenation. Neurofeedback can do the glial function. So ISF, or the Othmer system, can be hugely helpful. So in our clinic, we start everybody off with a few sessions of ISF as well to make sure that we don't still have that inflammatory cascade coming from the microglia. And I think you covered breath work and biofeedback. Meditation is fantastic. And I think it also helps with the cognitive behavioral issues. I'm not going to go into a lot of the supplementation, but it is very important to work with a functional doctor to help your clients. Basically, nutrition helps resource the body for growth. So, you were talking about your client getting reinfected. I think being able to detox and know that you don't still have the spike protein going is very important, and that we stop the inflammatory cascade. So, your functional doctor can tell you, whether to go with quercetin or whatever is available. But then there are also things like nattokinase that can help with the vascular, and endothelial tissue, D3 and NAC. All of these are very helpful. So in summary, neurofeedback and neuromodulation are a huge part of recovery from long COVID, because 80% of the people who present with long COVID have neurological deficits. That reset on the autonomic nervous system, that's so important. I couldn't have gotten back to work without being, when you stand up and you have tachycardia or you feel like you're going to faint. We were talking at lunch, and a friend of mine was like, "Oh, I don't think my husband has connected that, his POTS is probably associated with his bout with COVID." There are so many therapies, and it is a multimodal problem, and therefore we need a multimodal approach. And I think working with, people who are able to do oxygen therapy, HBOT therapy is very important. And I think you covered most of this. This is, let me go back. This is a case of a gal. Maybe I'm pointing at the wrong screen. Okay, it just won't stay. So this is a close-up of the checklist, but this is a 32-year-old gal who came into our office. She also had been trying different therapies and pretty much dismissed by her medical provider, as this was all in her brain, in her head, actually. And she was very severe. She came in pretty disheveled, shaking. Her dad had to drive her. She's a 32-year-old woman. She had not worked in 8 months. I looked at her checklist and I was a little frightened because I had worked with some COVID cases, but nothing this severe. She actually had some seizure type phenomenon happening. So here you see the beta on the theta. This is a low voltage fast buzz. Fast alpha on the motor strip, and the widespread SEBs. She also had some lambda going on, a lot of hypervigilance. Another thing that people don't talk about a lot is if you're hospitalized with COVID and facing death, you also have a PTSD look, and she did as well. Post-training EEG, much more synchronistic and organized, less temporal slowing. And we used oxygen therapy, we used V-light therapy, we had her meet with our functional doctor, and we did protocols led by the QEEG analysis. Still has some central CZ beta, but was able to sleep within about 15 sessions. Significant change in her beta rhythms. She was at about 22 to 30 hertz, and then her amplitude was now, well, her speed was now about 17 as her dominant beta. And her posterior dominant rhythm calmed down from being very erratic and going up to almost 14 hertz to being a nice 12. So she was a peak performer before she got COVID. And this is an overlay in WinEEG of, you know, how much you can see the slow wave went down considerably. And all of that, I think, was vascular ischemia with her. And then also the reduction of that beta excess. And then she got the rhythmic alpha in the back of her head. So that was a nice change. And then in our office, we just, this is something that clients can understand better than looking at the EEG or the quantitative EEG, is we were just mapping for each, you know, her beta voltage at FZ, her slow wave at FZ, her SMR at CZ, and then beta voltage from CZ to T6, because she did have the trauma marker as well. And so asking her to pick only 10 symptoms to rate on a scale of 10 was difficult, but these were the 10 that she rated at the most severe 10 when she started. And then within a month, we had a great reduction. She was off of one of her antidepressants. Then you can see, you know, her commentary here. As her symptoms reduce, better able to focus, haven't dissociated, less suicidal ideation. She's now only on 3 out of the 5 medications. All right, and by November, she was off 3 medications, and her sertraline was half. And then by the time, I think we took the second EEG in January, but we finished her before the holidays. She was off all medications. She was back to work. She was back in her right mind. And, you know, her, you know, she goes on and on with, you know, she had PTSD, depression, anxiety, severe brain fog, trouble breathing, fatigue, convulsions, tremors, which were a little frightening. I have video of this. I should probably play it at some point. But, you know, like I said, she was not functional when she came into our office. And within 6 months, she was looking like she had never had all of these issues. So that's the case presentation. So with long COVID, it is real and it is prevalent. And I would say, because 80% have these neurological changes, it's up to those of us in this field to not only get the word out that there's hope, because I would say that was what most of my clients come in with is, I've done this, 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 and this, and nothing's gotten better. And they tell me this is my new normal and I can't function. So being able to let them know that they can recover, especially the neurological symptoms, through neuromodulation and interventions. All right, thank you so much for listening. And if you have any questions, we'll take those after we speak with Jake. Do we need to do anything to get Jay up there?
Hello, hello.
Hey.
So I need to do a screen share as well. And they want a disclaimer on slides. Your first slide now needs to warn people that they have to practice within their licensure. Surprise, surprise. But it's a required APA first slide warning. So you're forewarned. a lot of this has been covered. This is an old presentation from 2020, so this is now 20 million, not 10. You've heard this previously from your prior presentations. Obviously, ACE2 proteins and arterial smooth muscle inside your blood vessels, basically, and inside your body endothelium, it can attack. But it also can attack glia, and that ends up being quite problematic when it happens. How does it get into the brain? This is mentioned briefly. It obviously can come straight through the vasculature, the optic nerve, olfactory nerve, trigeminal nerve. There, it can make it in. There's some other things where it doesn't have to enter the brain to have an effect on the brain. You can have hypoxia due to lung difficulties and have your oxygen level drop down. And actually, hypoxia can create edema, which can create ischemia. So, and obviously, hypoxia is bad. Anoxia ends up being potentially fatal. But the people who make it out of the ER off of the ventilators quite often have very severe neurological side effects that remain. And then inflammatory changes. If your body has an inflammatory reaction, your brain actually swells some. And that swelling in the brain compresses blood vessels. So it makes ischemia much worse. So let's this is a study that looked at inpatients, people that were hospitalized. Obviously, 82% of the people that had been hospitalized ended up with a neurological side effect. Some of them, it was just severe pain, some headaches, a vascular headache because of ischemia, migraine-like pain, but not due to migraine, but due to vascular ischemia. Encephalopathies, where they've got dramatically altered level of function. Usually that's a dramatic change in the brainstem's reticular activating system. Some of these people were not only just confused, but some actually lapsed into a coma, which is an alpha coma, which is a very, very severe encephalopathy. Some just had dizziness and disorders of taste and smell. So inpatients had lots and lots of neurological complaints. Very few got away without a neurological side effect. The thing is, it's not, when you think you're fully recovered, it's not necessarily that you are. In Ohio State, 15% of the college level athletes that they tested because they wanted to make sure that they didn't have problems. There were some athletes that had cardiomyopathy that had fallen, basically had heart problems on the field. So they were trying to avoid that. In the study, 15% of the athletes tested post-COVID had cardiomyopathy. So here we have an image of microvascular damage. This is an MRI in the brainstem showing vascular damage, but there was no local neurological infection. This is basically due to inflammatory changes and ischemia. So, what do we have here? We've got a lot of kids having multiple system inflammatory syndrome. These quite often end up being very, very severe. We won't focus on this as a subset, but these kids end up having severe long hauler problems, and as a subset, can end up being extremely severe. The brain pathologies that you can see: large vessel embolisms, basically a stroke. These are usually the people that were hospitalized. You can have viral encephalopathy where the brain has spindling beta, and that's actually a microglial effect. And you can have inflammatory encephalopathy where the brain swells basically and causes edema. And slowing. When you have edema, you see slowing. Now, slowing of what? And we'll see in a bit specific spectral processes showing what slows. And small vessel microemboli causing edema. And obviously cortical edema, just general swelling, it can cause edema. And edema causes ischemia. Now, ischemia is an inability to provide sufficient oxygen and glucose for full function. It's not the same as a full infarct where you've got a full blockage. This is a decrease.
Decreased blood flow.
With neurofeedback and biofeedback. Migraine, post-traumatic ischemia, the pounding headache you get after you've had a head injury. Local vascular changes with ischemia, people that had TIAs, and following stroke. We've worked with stroke patients. So we've actually got some history with these kinds of findings in the neurofeedback world. So it's not such a difficult step. Now, in the EEG, what do we see? Mid-temporal slowing, sharp, slow transients in the temporal lobe area. And this is an old paper by Niedermeyer, and he showed that 80% plus are vascular, primarily ischemia. Less than 20% of the mid-temporal sharp slow transients are actually just a not fully formed epileptiform discharge. Now, this is from the 1997 position paper back then by Mark Neuer and the American Academy of Neurology that most people think is kind of against QEG. Now, this particular document's been set aside entirely, but there was a section on cerebrovascular disease and the ability of the EEG, QEG to identify things in it. Tell me if this sounds like they didn't like EEG, QEG. When used by skilled professionals experienced in EEG interpretation, this is their caveat, sensitivity and specificity are high in detection of ischemia-related cerebral impairment, similar to focal impairments. These studies show sensitivities greater than 80%, good specificities, false positives below 5 to 10%, correlations greater than 0.7 between the EEG and blood flow, the ischemic and non-ischemic regions. Many were controlled, well-designed studies, some of which were prospective and blinded, which showed that the QEEG, get this, the QEEG could actually detect reliable focal features that were missed on the initial visual view of the EEG. Many tests can be quite abnormal, even when the CT or MRI, also here, are still quite normal, such as in the first few days after a stroke, and or when the degree of ischemia is not enough to cause an actual infarct. So that didn't sound so bad, you know. They weren't ranking on EEG, QEG being able to help with ischemia. And this is 2012, basically a review, like a position paper from Critical Care Medicine, saying that the quantitative EEG can not only detect ischemia in the brain, again, it's the slow edge of alpha, basically, but it also can end up being used to track treatment. And look at outcomes. So it can actually not only be used to detect or diagnose the problem, it can also be used to track the treatment. Now, they don't suggest neurofeedback. There's no linkage between the EEG diagnosis and watching the brain recover within this. However, let's look a little bit at the basic neuroscience of this. This is from Ian Cook, 1998, Journal of EEG and Clinical Neurophysiology. Delta is actually a positive perfusion. When your slow wave sleep is happening, your brain's busy putting out growth hormone. If you're unconscious because you're sedated like Michael Jackson, it doesn't necessarily do that. So I'd prefer regular sleep to Michael Jackson sleep, sedated sleep, and literally the hypnotics and benzodiazepines ruin the quality of sleep, even though you have more unconsciousness at night. Again, Michael Jackson was unconscious at night. Wasn't all that good an outcome for him. So hypoxia, decreased perfusion, is on this. Now, this is the mean of perfusion. 2 and 3 standard deviations of hyperperfusion, 2 and 3 of hypoperfusion, from about 3 or 4 hertz up to about 11 hertz or so. You have hypoperfusion. So very slow, below the alpha band, not just alpha. And a neutral positive perfusion happens from about 11 to about 16. And at about 16 on up, it goes into hyperperfusion. This is linked ears. Linked ears doesn't show local function very well. It's the difference between the ear and the location. These are Laplacian techniques, global and local Laplacian techniques, which focus on the electrode site's function. So if you're looking for perfusion correlates, don't use linked ears. Laplacian is the proper way to go here. And the brain regulates its own blood supply. If you turn on an area, it opens up the blood supply to the area. So what we need to do within a compromised blood system is to turn it on gently and leave it on so that it basically opens up the blood vessels. We can't create too much demand, because if you create a demand beyond the supply line's capability of supplying it in its existent impaired condition, you're going to create hypoxia, which is going to create edema, which is going to create a worsening of the ischemia. Why do you think they put a severe head injury person into a coma? To avoid all of the brain activity and allow the brain to recover before they put it back online to function and require blood flow. So a gentle positive perfusion over time opens up the blood vessels like a root raising a sidewalk. I mean, it's gentle, persistent pressure. And the SMR frequency band it is called SMR centrally, but it's not called SMR peripherally, or Barry will hunt you down. And I understand Barry's not able to be up and about and hunt you down right now, so I'll have to help him. So it's SMR centrally, but it's SMR-like frequencies elsewhere, and it's the same perfusion regardless of the location. So these 11 to about 16 range. A little faster, a little more perfusion, a little slower, a little less perfusion. So that we'll keep that in mind when we look at treatment. This is actually a raw EEG signal, and you don't have to really be an EEG expert. This is left to right frontal, F7 across to F8, T7 across to T8, old T3 to T4, and then old T5 to T6, now P7 to P8. You can see the biggest alpha in your eyes open shouldn't be coming out of F7. So F7 is responsible for word finding, verbal fluency, working memory, verbal working memory. Those are quite often the kinds of problems And this person also was complaining of a headache. An ischemic headache is like post-traumatic ischemia, migraine ischemia. If you have ischemia, you have vascular pain, headache. So this is the EEG feature. You can see the big peak. Now, if you look carefully, there's this little tiny notch here. Uh, uh, this little tiny notch right there is about 10. So there's actually some reasonably good frequencies, and 10 and a quarter, when mapped out, gives us, unfortunately, not a normal distribution, but there's some normal frequencies there. But when you look at the peak here, it's actually 8 3/4. It's even slower, and that's the area for word finding, verbal fluency, working memory, etc. So the slow edge of alpha tracks the pathology in this circumstance. And this is the kind of thing that we end up doing training to fix. Now, a couple references in the handout, but one additional reference is fairly new. It's a 2022, basically looking at neuropathology. They're basically looking at this hypoxic and ischemic injuries. That's basically what they're seeing, and you get that from inflammatory changes, obviously hemorrhages, um, brain hypoxia, neuropathologies, but what we end up seeing is hypoxic and ischemic change. And this again, fairly new paper. It wasn't on the list when I pieced together the PowerPoint. So let's look at EEG. So I've got a few. I don't know how much time I've got, but what I'm going to try to show you is a long hauler COVID complaint in an EEG, and then treatment.
How long is it supposed to go?
So um, this is the cleaned up EEG. Almost boring. Alpha, 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 with more alpha, with some alpha on the side. But you know, we can map it, and sometimes the mapping ends up helping kind of create the ability to see the detail. And this is the full EEG file going through a 4-second long epoch. It says quarter hertz resolution, and I'm going to colorize these. Alpha's in yellow. The alpha band, the nice peak frequency at the back of the head in alpha. Well, parietally, there's a slower peak. It's got some faster content, but there's a slower peak. And I don't know that I got the image of that. But there's an even slower peak. Some people would call this theta because it's in the theta band, but you can see it's a slow edge of alpha being optimized or maximized in the temporal area. What does the temporal area do? Well, this is Wernicke's area, comprehension and memory of language, comprehension and memory of affect. This person's got to have difficulty with frontal lobe function, memory, but comprehension and memory is just, it's not working very well. So let's open the treated COVID. Now, at the beginning, there's a little pulse artifact on an electrode, so that piece is underlined in blue. It won't be used. They stopped it, fixed it, and restarted. So that won't be used. The rest of this has been ICA cleaned, and although that's a controversy in some areas, it's not really a controversy in neuroscience, and not with me, that's for sure. So this is cleaned up. There's some brief moments that have artifact in them that are clipped and pitched. A subtle movement with slow waves, again pitched. But this is a much longer record than the pre. And here we are looking at the spectra and colorizing it. Does anybody see a difference? Now, there's still a tendency, the trend, but complaints are absolutely gone. Now, is the person doing perfectly well? That's a little bit of alpha up front, and I have to say that the raw coherence value is elevated. This suggests that there might be some affective regulatory things still going on. You got an elevated coherence up front, but the comprehension and memory, the ability to actually listen to somebody and understand what they just told you, Wernicke's area, that it's working well enough now that the person can take instructions and follow them. So let's look at the difference quantitatively. We can compare the initial one to the following one, but the direction of the graphics is going to be goofy. We're going to show the most current minus the prior, and the direction of the graphics will show the direction of change. So there's less activity at 7.3 hertz. There's more activity in the alpha band. There's less slow alpha, more fast alpha. And the more fast alpha, we can get the peak on it. There we are. So, 977 alpha is increased from what it was. The below alpha has decreased from what it was. And we can actually look at the coherence. The slow alpha coherence went down a bit. The faster alpha coherence is actually, there's more fast alpha, and the coherence there went up a touch as well. So we're back to the different spectra. When we turn this up, you can see basically the dramatic change here is essentially the slow edge of alpha was treated effectively to eliminate the neurocognitive consequence of the slower edge of alpha being present. So, and slow edge of alpha is ischemia, migraine ischemia, post-traumatic ischemia, COVID ischemia. That's still a headache. So the headache went away when the slow edge of alpha was treated effectively. And again, the most current, there's still a tendency. I wouldn't quit training this case. I would train until it didn't have that slow edge sticking out. So we had a nice symmetric alpha peak, and the alpha peak can be centered up. You could speed up the peak here, optimizing the brain function here. This is a 9.5 hertz peak. There's some faster alpha, so there's the possibility of having some brain brightening by giving the peak here just a little half a cycle a second faster. Get rid of that little tip and give it a little bit faster, a little bit of a smoother spectrum. But the EEG dramatically improved with treatment, and the treatment was CZ to the temporals, SMR frequency training, and suppression of the theta alpha band. Get rid of the hypoperfusion correlates, train gentle increased perfusion, suppress beta because we don't want muscle to solve the SMR frequency puzzle, and CZ to P7 old T5 as a montage is all that was trained. Simple one channel and another channel. They could be done at the same time. They're synergistic. same frequency pattern for training up and training down. There is a counterbalance to the SMR training. If you do SMR with more SMR with some SMR on the side, you become hyperstable. And excitation and inhibition have to balance. And we've just been training inhibition with SMR. So you have to be able to counterbalance that. Otherwise, you're going to be excessively, essentially sedated. And we don't want that. So we have to counterbalance. Usually counterbalance is some frontal training. You can see there's a little bit more alpha all the way up front than there is here, slightly quantitatively bigger. So we pick AFZ for the location instead of FZ, because AFZ is going to have a little bit larger alpha intensity, and AFZ can go to linked ears and help get rid of the temporal finding as a side effect as well. So we're suppressing the theta alpha band, suppressing the beta band, getting rid of this frontal alpha. Some people would train beta up here. It's an option. The intention is to get rid of the alpha more so than to train beta up. There's some people that have excess beta. It's not this person. Beta training for this client would be okay. But you can see, again, rostral anterior cingulate is probably the source here, 977. And this is 3.4, almost 3.5, and this is at the same frequency, 4.1. So it's bigger than this. So the source is further forward. And source analysis can be done to confirm that the anterior cingulate is rostral anterior cingulate is the source, but AFZ to linked ears, basically it ends up being the counterbalance in order to keep somebody, alert and aware and present. It also is the thing that would end up helping with the affective overlay, the alpha up front that had high coherence. Anyway, that's a little bit of EEG pre and post, and a brief talk. I think leaving it open for questions and discussion is probably the best thing to do from this point.
Questions. All right, let's see those hands.
This is a really good topic. I'm working with 2 severe long COVID cases, and one of them is starting to interview with the FDA. And I said, do not mention me. And so, how are you doing all cash? Or because I'm a psychotherapist and integrating neurofeedback and a bunch of multimodal modalities. And although it would be great for them to know what successes we're having, because she's doing, at least one of them's doing fabulously. But I don't really want the word to get out other than word of mouth. What are your thoughts?
Do you want to take that? Or
Sure. So I'm not sure what the FDA might have to do with it, but one thing you're bringing up is, there are 2 things that come up at least, and I hope this addresses your question. One is where Jay's first slide, we need to practice within scope. So in Massachusetts, where I'm licensed, I can't do any modulation. That's considered outside my scope of license. As far as coding is concerned, there is a biofeedback neurofeedback code. So if you are doing biofeedback or neurofeedback, you should use that CPT code 90901. There are also codes for EEG collection and EEG analysis and QEEG, although I think you have to be a neurologist to use that now. So you have to be careful. And Mark Trollinger is sort of the expert on CPT coding. And we are working to try to get some new codes out there, but that's a down the pike, hopefully not too far. But so we need to absolutely practice within scope, and our charts, our records need to reflect what we're doing as our CPT codes do, at least for insurance purposes. I'm not sure if that quite addresses your question. Well, so the fear of the FDA knowing, we use FDA approved equipment. The QEEG databases are FDA approved.
Yeah.
Oh. It's a giant head. So
you know, the FDA's regulation applies not to the practitioner, but to the manufacturer and their claims. Now, the field has got an interesting way around this. As an example, you can have a manufacturer whose claims are basically that I've got a device, it's got these specs, and you can buy it for this amount, and they don't make any real therapeutic claim. But they can have an affiliated but not the same organization that teaches you what you can use it for. Biofeedback, neurofeedback, the EEG biofeedback, neurofeedback has been approved basically for alpha training for relaxation. Well, we're doing a lot more than that clinically. But if you're a manufacturer, that's all you can claim because that's all that has been proven through the FDA 510K process. So, you know, don't you worry about the FDA. Manufacturers have to worry about the FDA. The clinicians can practice clinically within the scope of their practice based on published science that ends up being sufficient to be able to stand in front of your licensing board and defend your decision to treat. And you're not regulated by the FDA, you're regulated by your state licensing board. So practice within your license, have consultants that end up helping you. For instance, I have a client for Brain Science International, which, you know, again, I'm retired from that, but that client basically bills for the EEG, QEEG, but you have to be a neurologist. Well, what's the licensure for the recording tech? There isn't any. So what you basically have is the person signing the report ends up being what you end up being able to bill. So he ends up billing out for the work that's been done for him under contract, but he does the billing and he's getting paid. So you know, it's possible to build the EEG, QEEG codes without being a neurologist, as long as the consulting neurologist who's providing report services with you ends up being licensed to provide that. Anyway, it's always tricky. I'm a tech. I've always had to operate underneath physician oversight without question my entire career. So I'm kind of accustomed to it.
I add a comment. Hi, Jay. It's Mari here, and I'm not going to cause trouble this time. I'm going to make good. There's a little interior joke here, by the way. I'm not pro loopholes. I'm pro getting the job done by individuals who are qualified, and there are many individuals who are just doing fantastic work. So just get supervision. So please don't hide from the FDA, don't hide from your registered bodies, etc. We need to get the word out there, and this is one of our Achilles heels. So just get supervision. The other is, and I don't want to, support one manufacturer over another, but we have two manufacturers here now that have FDA and the Canadian equivalent technologies. So you can, if you choose those devices, you can stand up to the FDA. Okay. And they're Thought Technology and Brainmaster. If you choose to go with other manufacturers, get supervision. So there are ways, and chat with me on the side if you'd like, because I really want to encourage all of us to stop hiding under the table when we do this fantastic work. Well, that's my comment. Thank you.
I'd like to tag on to that comment about the CPT codes. Even if you're not going to get reimbursed, bill them anyway, because part of the decision making about whether to use and reimburse them is how many are put in, whether they're reimbursed or not. So just use them as much as you can, as appropriate.
One more is please look for what we call umbrella terms. Okay, we're all trying to find the exact precision. And if we all start using umbrella terms, and we had a little bit of an issue in Canada, you know, what is neurotherapy? So we said to heck with this, because we got so frustrated trying to explain to people who knew nothing about nothing. These are just insurance people who press buttons, yes and no. So we just use the term psychological services. So whatever your licensure is, or whatever the licensure of your supervisor is, or your qualified mentor is, use the umbrella term. So many ways. You have a comment there, Jay?
No, I'm just trying to read the chat.
Jay, I'll do it for you. We do have a question. Dr. Johansson mentioned CES on vagus nerve. I use CES on the ears. Are you using the MED version of CES on the vagus nerve? How are you doing it? And I probably butchered that. Excuse me, people.
Yeah, so there are a couple of ways, but you know, just on the tragus on the ears instead of the earlobe. But you know, with the home device that I have, you can also, you know, just use the biofeedback and track the sternocleidomastoid muscle and place the sensor there for the CES. And both of those are going after that vagus nerve stimulation.
Are there any further questions from our virtual friends or our in-person audience? If so, please raise your hand. Well, with that, I would turn it back over to our co-presenters if you have any final comments.
No, I just appreciate the opportunity and appreciate all of you being here.
Absolutely. Thank you for coming.
Well, Jay must have something to say.
I'm just sick and tired of having to miss everybody. I do have people pop in here because I can't go anywhere anymore. So in October, folks pop in here for a few days to talk about EEG and hang out. And you know, sorry to say, but it's like a 3-day party. You know, it's EEG based, but if you're not having a good time, there's something wrong with you. So
we're all invited, right?
You're
Where do we
all
get
invited.
yeah, and we did it last year, and we were disappointed that we couldn't have more people because there was more demand than there was space. So this year we're going to do streaming of it for people who want to kind of catch the coattails of what's left if you're not there in person. And Dr. Ritter's coming in from New Zealand and Martijn from the Netherlands, and we're going to hang out for a few days with a lot of other folks as well. And we take over the yacht club, which has a bar. So anyway, that's
A lot of good neuroscience happens at the bar.
Yeah, absolutely.
yeah. Anyway, for a little tiny town of 29,000 people, they were shocked when 80 neuroscientists were wandering around town for a few days. You know, it's a very small, quiet little town, but they were shocked at the presence of all these very well behaved neuroscience folks for the week. So.
Jay, how do we get details? What's the website, or will there be emails?
Talk to Sherry. She's one of the organizers, and
all right.
I don't want to hawk it that much from the stage here. So,
Jay, we love you so much. We miss you. We'll see you in Cali this October. So thank you for everything. And let's give everybody a big hand again. Wait,
Bye
Hey,
bye.
Jay, I just want to say hi. This is Ron Swarzina. I missed
Hey,
you.
Ron will be there too.
That's right.
I will. And thanks.
Okay.
I mean, it's an honor, sir, every time we see you speak. Thank you so much.
You know, we have a band hired this year.
I heard.
So, oh well. More party talk later. So.
All right, sir. We'll catch up. Thank you.
Thanks.